Hello, everyone, and thank you for joining us for this first of 3 stroke topics that are designed to expand and refine your EMS stroke recognition, care, and communication skills. Now, you may recognize the Mission Lifeline logo here as the American Heart Association limb that in the past had administered a large grant to improve STEMI care in Montana. Well, heart disease and stroke share a lot of the same pathological and etiological features. They're really sort of the same event, just kind of happening in a different place, but they have the same risk factors. So we're really grateful to the American Heart Association and to Mission Lifeline and the Helmsley Foundation for this opportunity to improve and build stroke care in Montana. So let me introduce myself. My name is Penny Clifton, and I am the Stroke Program Coordinator for St. Vincent Healthcare here in Billings, Montana. I am part of a 4-person team that's responsible for all of Eastern Montana and your EMS stroke education. I am joined in this effort by Kyle Gibson, who's the, I'm going to say the flight nurse leader for Stat Air, Northeastern Montana Stat Air Services. Peggy Stribley, who is currently the stroke coordinator for Billings Clinic. She'll retire shortly, but is going to stay on as a partner with this project. Peggy built the stroke program at Billings Clinic over the last 14 years, and we're grateful to have her continued involvement. And then Sarah Lewin, who's the battalion chief and EMS officer for Miles City Fire Rescue. So between the 4 of us, we hope to get you primed and ready to improve the excellence of your stroke care in Eastern Montana. So today we're going to provide you with an introduction to stroke as an illness, because I think when you understand what's going wrong inside of your patient, then your assessment and your interventions, they just make a whole lot more sense to you. And over time, as you have different patient experiences, you build kind of a database for yourself of different contexts of stroke patients, and it helps you to flex your skills and adapt to different types of patients as you identify them. So after that, in part 2, we'll talk about how you identify stroke, your care, and your transport. And then in the last piece of it, we're going to take it all and put it all together and use some actual real patient scenarios to help you test and practice those skills. So let's begin. And again, I'm Penny Clifton. I'm the Stroke Program Coordinator for St. Vincent Healthcare, and I'll be your instructor today. By the end of this session, my hope is that you'll be able to list some of the EMS related goals for Mission Lifeline Stroke Montana. I want you to be able to define stroke. I want you to be able to describe stroke risk factors. And this is important for you personally, and also important because a patient's past medical history kind of fine tunes your assessment radar a little bit. You know how that works. And I want you to be able to state what the current treatment options are for patients with stroke, including the new things that we're working on offering in Eastern Montana. Now, as a little bit of a context, let me tell you some history so you can understand why this is important for Eastern Montana, why a system is important. I moved to Montana in 1989. And in 1990, the Montana Department of Public Health and Human Services began what was called a trauma preventable mortality study. They wanted to determine why the death rate for trauma in Montana was the highest in the entire nation. They hired some outside physicians to review all the trauma records across the state, and they found an alarming rate of miscommunication between EMS and hospitals, and between hospitals and hospitals. And they found an alarming rate of practice areas, specifically with regards to early airway intervention. Not surprisingly, they also found, of course, that we drive excessively fast and we didn't have good speed limits and nobody was wearing a seatbelt and everybody was driving under the influence. And you know, all of those things that you recognize intuitively. So in response to this, they divided the state into 3 regions, each under the leadership of one of the 5 largest hospitals. The surgeons and the nurses at these hospitals developed a statewide trauma knowledge base using the Advanced Trauma Life Support, or ATLS class, and then TNCC for nurses and PHTLS for you, and they rolled this out across the state. This knowledge base then produced a shared language of communication and care standards across the state, and it filtered out into the smaller facilities and smaller rural volunteer EMS groups. And of course, there was enormous public education about seatbelt use and driving with not driving under the influence and using helmets on motorcycles and stuff like that. And then they repeated the study about 4 to 5 years after that. And they found that what they had done, which amounted to a system of care, had dramatically reduced medical error, had dramatically reduced preventable deaths, and had dramatically improved the communication about trauma patients across the continuum, from the field to the critical access hospital to the stroke center. So what I need you to recognize is that stroke is as time sensitive as trauma. And in stroke, time is brain. And so stroke needs a system. And we are doing the same thing now with Mission Lifeline that they did with trauma so many years ago in trying to build a system of care. So it's our hope that at the end of the 3 years of this Mission Lifeline grant, we will have a public that recognizes stroke signs and responds quickly by calling you, that we will have EMS teams that recognize stroke, can identify specific stroke signs, care for stroke on way to the hospital, and communicate in a really clear way the important care pieces that help to facilitate our response as a hospital. That the hospitals will be able to provide consistent evidence-based and national stroke standard assessments and care, even including the use of telestroke. And that at the end of everything, the patient will have access to a high standard of rehabilitative care to help them recover from their stroke. That's the overall goal of Mission Lifeline Stroke, is a system of care. And I think because all of you were part of the trauma system, a little history about how that trauma system got to be as mature and robust as it is might help you to understand the vision that we have for stroke. So a system of care is something that ignites when the patient enters the chain. We need a system of care in the hospital and in the community, because both of those will minimize the delay to care that patients experience, right? So we're going to talk specifically about EMS today. Why do we need a system? Well, it reduces all the delays in communication. It gets the patient the right care at the right time, in the right way, in the right place. And because you know from your experience that other time systems, other time-sensitive things like trauma and MI. In trauma, the longer an injured patient goes without oxygen or bleeding control, the more likely they are to die. In heart attack, the longer a patient goes with infarcting myocardium, the more likely they will be left a cardiac cripple with a useless pump. So I need you to grasp that stroke is exactly the same, because the longer we let somebody stroke, the more likely they are to have a permanent disability that will take from them their ability to live on their own, their ability to work, their ability to drive, their ability to parent, their ability to communicate. A system saves lives, saves hearts, and saves brains. Now, on this slide of these mind-numbing statistics, I think it's important for me to emphasize to you that these numbers have not changed in years. The stroke rate has not changed. And in fact, if anything, the numbers of people of a younger age having strokes has gotten higher because of lifestyle choices. So even as the smoking rate seems to have fallen, all of the dreadful diets and the remote control gaming, smartphone kind of lifestyle have reduced many people's activities. I want you to notice that stroke is a number 5 cause of death in the United States. So when I talk to you about your EMS care, I'm not really talking to you about mortality rates and saving lives. What I'm talking to you about is saving the quality of life, because your care reduces disabilities. The other equally important issue with time and EMS is that all of the treatments that we have are linked to the clock. There are specific time windows for treatment. There's a time window for the treatment of the clotbuster drug. There's a time window for the new treatment of reaching into the patient's brain with a little claw and pulling that clot out that's causing the stroke. But they have time windows on them because there's a limit to the benefit. You can't give the clotbuster drug after a certain period of time, or it's more likely to make the patient bleed in their head than to help them to have any recovery. I also want you to know that there's an alarming statistic unique to Montana, that 1 in 3 stroke patients is under the age of 65. Now, this girl talking to you today is 62. So this is me, and this matters to me that the age of stroke has gotten younger. And I want you to be aware of that also, because we used to historically link strokes to the elderly. And I need you to grab that it's not the elderly any longer. It's still people like me and yourselves who are still working, still actively part of the workforce, driving, recreating, raising kids, all that kind of stuff. So expand your knowledge base and your radar to include people of a younger age. And as an illustration to this, let me share with you these pictures of these Montanans who all had strokes under the age of 65. And their strokes cost them their businesses. It cost them their homes. It cost them their ability to speak and to live alone. It cost them financial security, their jobs, and the things that they loved to do to give themselves joy, like fly fishing. These are your neighbors in Hamilton and Billings and Great Falls. They are us. So the biggest definition of stroke, the overarching definition, is that a stroke is a sudden arterial blockage or bleeding that is not related to trauma. It results in brain tissue ischemia and infarction, just like myocardial ischemia and infarction. And then in the area that's ischemic and infarcted, the patient loses those functions. Depending on the size of the ischemia or infarction or the size of the bleed in a hemorrhagic stroke, obviously this can even result in the death of the patient. I want to also emphasize the word sudden. A stroke is a sudden event. It's important for you to recognize that because it is the characteristic for you to listen to when you're gathering a patient history. Sudden can mean it happened right in front of friends or family. Sudden can mean I went to bed last night normal and I woke up like this. It's a dramatic change, and a person can either say right when it happened, or they can tell you when they were last normal. And so I guess what I'm saying here is that strokes don't tend to evolve over time and get a little worse every day. They tend to be sudden events, and that's what we teach the public, and that's what we want you to grab as well. There are two types of strokes we will talk about today. The more numerous type is the ischemic stroke. This happens with a blockage, with a clot. The clot can either be, can form in place in the brain. We call that a thrombotic ischemic clot. Those are the kind of strokes that happen with people with diabetes and hypertension, drug users, alcoholics, stuff like that. Or it can be a clot that flows up from the neck out of the heart. We call that an embolic stroke. Those can be clots that break off from sludge in the carotid arteries or the basilar artery in the back of the head, or clots that form in the clot due to irregular heart rhythms, such as atrial fibrillation. The second and less frequent type of stroke is a bleeding stroke called a hemorrhagic stroke. This is due to the rupture of an artery, and pretty much without fail, this is from unmanaged hypertension. There is a subset of these bleeds called a subarachnoid hemorrhage, which is due to an aneurysm rupture. The aneurysm rupture type subarachnoid hemorrhagic strokes are the ones that are associated with that classic thunderclap headache and worst headache of my entire life. I won't deal with these subarachnoids a whole lot here because they are so rare, and we can capture them underneath of the definition of hemorrhagic stroke. And there isn't really any change in your care at all, except that you would report that thunderclap nature to the headache and that it was the worst headache of their life. So that's important to capture in your assessment. Okay. Understand also that with these hemorrhagic strokes that I just mentioned before, I want you to know that methamphetamine and cocaine in Montana contribute a lot to this population of hemorrhagic stroke. And in fact, there is research showing that every single exposure to meth causes a little bit of a stroke at the tips of those arteries. And eventually it just becomes a big, ginormous event. Now, regardless of the type of the stroke, there is a portion of downstream brain tissue that was waiting for that oxygenated blood that was either blocked by a clot or lost because of the hemorrhage. And when the dust settles, this area of brain is just kind of gone. This space is infarcted, the dead tissue gets reabsorbed, and there's this kind of space left. It's just sort of a void that'll show up as a dark spot on the CAT scan. It just kind of gets filled in with cerebral spinal fluid. Most importantly, though, everything that lived there, every bit of function, every piece of learning, that's now gone. So I can tell you by looking at this stroke, this is a left hemisphere stroke, and based on its location, this person, had they survived, would be unable to speak, unable to understand the words that were spoken to them, would not be able to see the right side of their world or move or feel the right side of their body. So I did describe to you some motor skills, the moving of the right side of the body, but the most important piece that lived in there was all of the learning about speaking and writing and reading, all of those sort of cognitive things. That helps you to understand how devastating the impact of these events can be. Now, when we talked about the similarities between stroke and heart attack and about why the stroke rate hasn't improved, I mentioned to you risk factors. Part of a system of care is going to be public education about reducing the risk of a first or second stroke by getting risk factors identified and by patients beginning to work on the ones that are controllable. This is actually a big EMS point, believe it or not, because first of all, knowing these risk factors can help guide the questions that you ask a patient and family about their history. And when patients are hesitant to let you transport them, knowing these risks that they have can help you advocate for transport with language like, no one wants to go to the hospital, sir. I understand that. My concern for you is that what I see and what I hear sounds a lot like you were having a stroke, and you have a lot of things in your medical history that point to stroke. And I really think you need to let me take you in and get checked over. As Montanans, and considering the number of Native nations we have in our state, I also want you as EMS people to recognize that our natives, and especially Native American women, have the largest stroke risk and death rate of all Americans. So the things that patients are able to control are going to be things like high blood pressure, high cholesterol, their diabetes, the choices that they make with substances, how active they are. The things that are obviously not controllable will be their age, and as you get older, the arteries get stiffer and more diseased over the course of a lifetime, more likely to generate a stroke. For reasons that are a little unclear, a stroke has a higher impact on women. And I mentioned to you the impact of being a Native American and how much that increases the stroke risk, probably because of the high propensity for high blood pressure, high cholesterol, and diabetes in that population as well. Okay. Right. Now, in ischemic stroke, and again, these are the ones that are the most numerous, this graphic helps to illustrate a clot-based stroke. See how the clot is stuck in that artery? Now, there's much less oxygen-rich blood flow going past that blockage. And whatever the functions are that that oxygen-starved section of brain had, those are what are going to show up as the stroke signs in your assessment. So, quick challenge. If this is a left brain stroke, what side are the stroke signs going to show up on? And you would correctly say the right side. Again, this is a clot that can be a thrombus that formed there, or it can be an embolus that floated there from the neck or the heart. Now, this picture is also interesting for another reason. It shows a fairly large clot pretty close to where the blood entered the head in the left carotid artery. Now, as you're a Montanan, you're likely familiar with irrigation dishes and head gates and the tubes that they use to irrigate fields. So a large clot stroke is kind of like having a malfunction at the head gate. The whole field goes without. Now compare that to a clot in just one of the tubes that is used to irrigate a row, only the row goes without blood flow or water flow, correct? These large clots, they affect a lot of brain tissue. And in section 2, we're going to talk to you about how to recognize the signs of large clot, because there are now treatment options to reach into the brain and pull that clot out. And we want you to be able to recognize these patients and communicate about them for that reason. The second type of stroke that I mentioned to you is a bleeding or a hemorrhagic stroke. It is usually related to hypertension. It is not related to trauma. And most of the time, the bleeds occur down deep in the substance of the brain where the arteries are so fine and so fragile that really after years of elevated blood pressure, or frankly, a single hit of meth or coke, their weakened wall just ruptures and blood escapes into the substance of the brain. Now, this blood is an irritant, which is one of the reasons patients get headache. But the other thing it does is it takes up space, which makes it similar to trauma, because in trauma, blood takes up space in the brain case, in the skull case, where there's no really room for anything else like that. So this bleeding takes up space in the fixed box of the skull, and it increases pressure in the skull. The irritation and the swelling often cause a sudden bad headache, and they cause drowsiness along with the stroke symptoms that would manifest on the other side of the body, correct? This is different from ischemic stroke because ischemic stroke doesn't take up space. Those patients don't tend to lose consciousness. They do not tend to have headache. And it's because of this pressure issue and because of the increasing in, pressure inside of the head that these patients are most likely to be the ones to lose consciousness in the ambulance and need some sort of airway support from you. Sadly, because this is a hypertensive related stroke, the only thing we can really do for these people is to try to get their blood pressures down. In fact, in this graphic image, you can see that in order to operate on this bleeding and go in and take it out, a surgeon would have to go through healthy brain to get to it. And that is just not a risk that they think is worth the benefit. So all we can really do for these people is to control their blood pressures and try to control their swelling with other methods. Now, you know that there are some medications out there on the market called anticoagulants, not aspirin. Aspirin is an antiplatelet, but anticoagulants like warfarin, which you may know as Coumadin, or Eliquis, or Xarelto, or Pradaxa. Those are all anticoagulants. They double the amount of time it takes somebody to make a clot. And for the most part, we use these medications for people with atrial fibrillation, because the irregular heartbeat makes clot, or for people who've thrown a clot to their lung or had multiple clots in their legs to keep them from making clots. So you can imagine that a hemorrhagic stroke might be a consequence of unmanaged hypertension and one of these medications. So that would be the only other treatment we could offer, would be if we knew that they were on anticoagulant drugs, to try to reverse those medications if at all possible. But again, that makes it really important when you gather a medication list from the patients and the family to identify that they're on those drugs. So upon arrival in the emergency department, once we're confident that the patient is not unstable from like an airway, breathing, or circulation standpoint, then they go right to head CT. In fact, down here in Billings, where they pretty much, they get a once over in the ED, and then they're still in their street clothes. And lots of times we'll have AMR just take them right into the CAT scan booth. This CAT scan is that important. The basic question for us is this a stroke? And if it is it ischemic or hemorrhagic? It's also possible, by the way, for us to tell the age of the ischemic stroke by looking at the CAT scan. Now, I've talked to you before about how to kind of how to read CAT scans, and I've told you the CAT scans are not about function, they're about density. So things that are very dense, like blood and bone, are white, and things that are not dense at all, like water, are dark, and brain is somewhere in between there. So you can see about how the image on the left there, that's actually a perfectly normal CAT scan, with the exception of the fact that I know from this case that this was somebody having an ischemic stroke. But you can see how perfectly symmetrical it is. There's no dark spots in there at all. Everything's laid out completely normally, because it's going to take about 4 to 6 hours for the cells, the infarcted cells, to leak enough to create the dark spot on the image on the right side of the screen there, which is the same stroke about 6 to 8 hours later. So if we go to CAT scan with somebody who shows up with acute stroke signs and we get that image on the left, it doesn't tell me they're not having a stroke. It tells me it's early enough that they may fit in the window to be treated with that clot buster drug. The patient shows up with stroke signs and I have the image on the right, it lets me know they've been at that infarction for a while and they are outside of the window for clot buster drug. Now that you've seen an early and late ischemic stroke on CAT scan, you should be able to immediately recognize that this is a hemorrhagic stroke, a reminder that it's down deep in the substance of the brain. This is not due to trauma. And because it's blood, and because blood is dense like bone, it's white and it is immediately visible on the CAT scan. And this is why the CAT scan is so important. It tells us bloody stroke versus not bloody stroke, and it might even tell us the age of the clot stroke if it's an ischemic event. Now, before we move on, I want to tackle something that I know that you've experienced. You get called to a stroke and you get there and the symptoms are better or they've gone away and the patient doesn't want to be transported. Now, you can't force them, but you can inform them. So here is your language. You know, when the dispatcher called me, it really sounded like you were having a stroke. So I'm really glad that your signs went away, but here's the thing. A stroke is usually caused by a clot. And if you make one, you can make another one. And maybe this one, your body's not going to be able to break it down fast enough before it hurts you. If I were you, I would go in and try to find out why I made that clot in the first place and see if there's anything we can do to keep you from making another clot, which might be a bigger, real stroke this time. The T in TIA means transient. These signs should go away in less than 30 minutes, and patients should have absolutely no stroke symptoms left at the end of it. The way this is theorized to happen is that, your body has its own clot busting mechanism. It's actually the human form of the drug that we give. And so the body can eat the clot and get rid of it if it's small. So if you think about that for a minute, the larger the clot is, the longer the symptoms are going to last. And the more numerous the symptoms are going to be because of where that clot landed. It takes out a bigger geographic area, right? A bigger section of the field. So it should be transient. It shouldn't last long. They shouldn't have any symptoms left over it. But when you listen to them describe it, and they're telling you how long it lasted, or they tell you the scope of the symptoms, that's the thing that really should give you the power to say, boy, this sounds like a really big event, and you need to go in before you have another one. What I don't want you to use is, please don't use the language mini stroke. There's no such thing as a mini stroke. There's no such thing as being mini pregnant. You either are pregnant or you aren't pregnant. So this language just minimizes it and makes patient not take it seriously. So I want you to take it seriously so that they do. Okay, good. Now, when you arrive in the emergency department, the staff should have an established plan of care, and it's going to be based on what you told them over the phone. They should have an idea for what they think they're looking at. They should have called their CAT scan people in. They should be sort of ready to go. So your handoff is really important in the way that you give this information. And we're planning on building some EMS handoff tools for you for stroke, and also some handoff tools for the critical access hospitals to use with the larger hospitals, because it's really important that the information be given in a really cohesive, coherent fashion, using the right language and capturing the important pieces. Now, this isn't something we're going to require you to fill out, obviously, but it's just going to guide the dialogue. In ED, obviously, the most important piece is to make sure that airway, breathing, and circulation are stable. Obviously, that's the most important piece. And, if you weren't able to get a line, we might be able to get one real quickly, as long as it doesn't slow us down for going to CAT scan. But for the most part, the providers are going to do a Domino Nabisco and look them over. And if they're safe to go to CAT scan, they're going to CAT scan. Now, during all of this time, the emergency department is going to be extending the care that you already started. In other words, they will be making sure this patient's blood pressure stays up. And just as a warning, these people are never hypotensive. In fact, most of the time they're so hypertensive, it makes you a little nervous. But hypertension and stroke is actually a compensatory thing for us in a lot of ways. It's almost diagnostic in its own way. That blood pressure is high because something's wrong in the head. So we kind of leave it up there until we get the CAT scan to see which path we're going to take, right? So we make sure they're not allowed to drift in their blood pressure. We keep their oxygen saturations up. You would have already checked the blood sugar and treated if it's low. We're going to do the same thing. If their patients are febrile, we cool them down. If they're cold, we warm them up. And all of these things are supportive of their brain until we can get that CAT scan and figure out what path we're going to take. Because those things, if you don't fix low blood pressure, you don't fix low oxygen, you don't fix low blood sugar, and you let a patient have extremes of temperature, you cause them a secondary insult and trauma. Same is true for stroke. The final thing that I'll mention to you that is different is that lots of times the stroke affects somebody's ability to swallow. It either makes it so their tongue doesn't work and their speech is slurred, or they're not really aware of, can't feel what's in their mouth. And this raises their risk for aspiration. And I tell you that because I've had families think that they need to give the patient an aspirin. And I just want to make sure that you discourage that if that kind of looks like it's going to happen in front of you. So treatment was going to depend on what type of stroke this is. So if it's a stroke due to a clot, then the treatment will be to try to break up or remove the clot if the patient's in a safe time window to do that. If it's a bleeding stroke, then our treatment will be to try to stop the bleeding by controlling the blood pressure and reversing any medication that might potentiate the bleeding. And of course, treatment will be to doing all those things to protect the brain, the whole time. Historically, there wasn't a whole lot that we could offer people. I graduated from college in 1981, and by 1993, the only thing we had to offer stroke patients was this clotbuster drug called Alteplase, and that was all we've had to offer them up until about 2017. Alteplase breaks up clot, and any hospital in Montana that has a CAT scan should be able to identify ischemic stroke and differentiate it from hemorrhagic stroke, and should have this drug in stock. You can see why, since the drug has a time window, we can't give it if the patient's been infarcting for more than 4.5 hours. You can see why EMS's ability to tease out how old the stroke is becomes just a crucial piece of the information that you collect. So the biggest issue for us really is going to be time. What I want you to look at as a provider is I want you to look at your skill set with how you ask this question. I want you to think about the value of phrasing it this way. Think about what you would get if you said, were you with him when this started? Which is different than, when did this start? Because from a family standpoint, as far as they're concerned, it started when they found their father on the kitchen floor, when really what you need to know is, was anybody with him when this started? Because if they weren't with him when it started, then the time you need to capture was, when was the last time anybody saw him and he was normal? Which is tough because it really rolls the time of the clock back, but that is the question that we have to ask. So how does this drug work? So from the moment the ischemic stroke starts, there's brain that's damaged, and there's part of it that we're not going to be able to get back. It's infarcted, it's the core, it's done. But this damage kind of spreads like an ink stain. And if you can protect that spread from happening, then you can minimize the amount of disability the patient's going to have. That's what the drug does. By breaking up the clot, it helps to restore arterial flow to the area that was threatened, preserve the threatened area, and then the threatened area becomes the area of brain that they're going to do their rehabilitation with. This drug, when you give it, there's very few people who in front of you in the emergency department, the stroke just stops and they're all of a sudden normal. That's not really how it happens. For the most part, though, when the research was done, and we're talking about thousands of people in the original research and millions of people since the research was done, when you look at these people 3 months out, these are the people that are in their own homes. These are the people that still drive. These are the people that are still working. These are the people that can still dress themselves and speak. That's when we see the benefit, not necessarily at the front end, but 3 months later. And that's what it's all about, is reducing the disability with stroke. Now, there's a new treatment for ischemic stroke that's happened in the last 3 years. Remember I told you that we really have this really tight time frame of 4.5 hours limits with this drug. So, when you would pick somebody up who said to you that they went to bed normal, and then they get up at 6 o'clock in the morning and they're not normal anymore, well, hell, that would boot them right out, wouldn't it? Because they were normal at 11, but now at 6 a.m. they're not, because the stroke happened sometime while they were asleep. The thinking was, for doctors, they wondered if it wasn't the stroke that was waking the patient up. And we were really actually closer in time frame to how fresh this stroke was than we realized. What we found was that we could put the patient into an MRI machine for a really fast set of scans. We would just do 2 sequences instead of the bunch of sequences that MRI usually takes like an hour. We could get this done in like 10 to 15 minutes. And we would look at the difference between 2 types of sequences. Now, without going into a lot of detail, there's DWI and FLAIR. DWI is diffusion weighted image, and FLAIR is fluid attenuated something I don't even remember. But here's the deal. If the stroke is white on DWI and not there on FLAIR, this is a brand new event, less than 4.5 hours or so, and we can treat them. So you look at the top row, you see the difference. Bright on the DWI, nothing on the FLAIR. That's a treatable patient on row A and row B. But look down the bottom, and you can see in the same patient under C and D, white on the DWI, white on the FLAIR, that stroke's beyond 4.5 hours, and we can't treat that patient with alteplase. So here's the first category of a new treatment for stroke. Same drug, but a different treatment window, using MRI to help fit the patient back into the treatment window. So again, the language that you use when you question the patient about when this happened and when they were last normal can really change the trajectory of how we treat. But now let's look at the really exciting one. So this therapy is called endovascular therapy, or mechanical thrombectomy and clot retrieval. Now, you'll recall from an earlier graphic picture that I showed you that large clots tend to get stuck right after the blood makes a hard turn into the brain after coming up either the carotid arteries in the front or what's called the basilar artery, which is in the back of the brain. This location of the clot, close to the turnoff from a big artery, is what makes them reachable, because there are stent retrievers like we use with heart attack that can be threaded up those big arteries and grab that clot and pull them back out. Now, this procedure is called thrombectomy, mechanical thrombectomy, and the providers that do it are interventional neurologists or interventional neuroradiologists or interventional neurosurgeons. Hospitals that have developed programs for clot retrieval are generally called certified thrombectomy capable primary stroke centers, or the bigger ticket item, bigger center, are comprehensive stroke centers. So there is currently no certified thrombectomy capable primary stroke center or comprehensive center in Montana. But we have St. Patrick's in Missoula, who does have the ability to do thrombectomy. And I will tell you that the hospitals in Billings, Montana are both on a path to become thrombectomy capable in 2021. So similar to a heart cath, the access points for this are an artery in the wrist or the groin. The retriever goes through the clot, opens, captures it, and pulls it back with the clot inside the retriever. The patients are then admitted to ICU for 24 hours or so of surveillance. Patients who are candidates for TPA and have a big clot can have both of those treatments. But in the image on the right, you can see by pulling that clot back, that whole penumbra, which would otherwise be dead, is now saved. And now that patient can use that tissue to do rehabilitation. This is a pre and post cerebral angiogram. I will tell you that the camera is actually pointed at the patient's face. I know that's hard for you to appreciate. The dark line on the left-sided image, the dark line is the dye outlining the patient's carotid. And where there's kind of a big dot in the center of it, that's not the clot. That's when the carotid actually takes a hard turn and kind of comes towards the camera. But notice that it just sort of stops. I mean, there's no flow beyond the end. That's the image on the left. But when they pulled that clot out, I want you to look at the scope of the blood flow that was reestablished to that patient's left hemisphere and how much brain would have been ischemic and infarcted had they not pulled that clot out. Now, the treatment for this procedure, the treatment window for this procedure, believe it or not, is up to 24 hours. That means that patients up to 24 hours from the start of their stroke have experienced reduction in disability from the withdrawal of clot. Now, this doesn't mean that everybody up to 24 hours is a candidate. Obviously, the patients out at 23 hours are going to be the smallest piece of the pool. And in fact, the most benefit is achieved by patients within the first 6 hours. But again, now we have MRI that can help us give patients TPA if they wake up in the morning with their stroke. And we have this that can help patients get a reduction in disability, even if the stroke is way beyond the usual treatment window. So a large reason why Mission Lifeline has come to Montana is because we need EMS and smaller facilities to be able to identify these patients and help get them expedited to clot retrieval so we can reduce the disability. It's kind of like an early warning system for storms. I mean, there are signs you look for in the weather that help everybody listen for the announcement to get ready to prepare. Well, it's the same for this. We want you to be looking for the signs that indicate that a big stroke is on the horizon, so that hospitals get prepared for these patients to come in, so they're ready to give them clot retrieval when we have the capacity. Right now, until we can get this service built in Billings, we're sending these patients to Denver and Utah, and we want to be able to bring the service closer to home. I mean, heck, who would want to be in the air for 3 to 4 hours still having your stroke when we could do the service here in Billings? So I just want you to know that we are all working on that capacity here in Billings. So for hemorrhagic stroke treatment, we haven't got as much. We can reverse their anticoagulation, reverse their warfarin. If we're lucky, maybe there's a reversal for their Pradaxa or their Eliquis or their Xarelto. We can immediately get their blood pressure down, but we're not going to go in and take that bleeding out because we got to go through healthy brain to get to it. If the brain really swells a lot, you can take off the a piece of skull. It's called a craniotomy. Just kind of let the brain swell, and you put the skull cap back on a little bit later. They can also drain out cerebral spinal fluid, and that makes up, a little bit of extra space in the brain for the swelling to move into. For subarachnoid bleeds, which I'll remind you are due to aneurysms, there is nobody right now clipping or coiling aneurysms in Montana. So these patients do need to be sent on to large centers in Denver and Utah to have their aneurysms managed. So in summary, There are some new treatments for ischemic stroke, but like the old treatment we had of the clotbuster drug, they're time-sensitive treatments because stroke is a time-sensitive illness, just like trauma and MI. Even though there's no thrombectomy in Montana right now, the accuracy of your assessment and the accuracy of your communication and the safety of how you transport patients can really help reduce disability. There are new treatments for ischemic stroke. They're time sensitive. Stroke is time sensitive. Just want to repeat that because it's important. EMS is the first to see the patient. They're the first to hear the story. You're the first focused Mayday or SOS that gets sent up about the event. The whole chain of stroke care kicks off with what you see and with what you do and with what you say. So in a few weeks, we hope to have part 2 ready. But this gives you the knowledge upon which to base your skill. That's what this section was about. And I'm really grateful to you for watching it. And then I hope you'll be able to engage and reach out to us so that we can bring part 2 to you about EMS stroke identification, care, and transport. I'm certainly ready for any questions. My email is always available on the state stroke website. And I would encourage you to reach out after this presentation to ask any questions related to this topic. Thank you.
All right. Thanks, Penny, so much. I am going to push stop recording and we're all set. That was awesome.
That was okay, though?